Okay,
You see my slides? Like it's
it's
not
perfect.
there. Okay, great.
Good day for everyone. On behalf of the cardiology program at the University of Antioquia, it's a great honor to welcome you to another session of Cardiology Approaches series. Today, we are privileged to host Dr. Yuya Matsue, PhD, Associate Professor of Cardiology at Juntendo University in Tokyo. We are grateful to have him with us today to share his expertise on this topic of acute heart failure. And it is my great privilege to now invite Dr. Matsue to take the floor.
Okay, thank you very much for having me. I'm I was introduced Yuya Matsue from Judo University Hospital in Tokyo, Japan. It's my honor to be invited to such a great meeting regarding the focusing, the meeting focusing on the one of my favorite topics, okay, heart failure. So as a background, I'm a heart failure cardiologist, focusing very much on the research, critical research, basically, and also while I'm working as a heart failure consultant in the University Hospital. So let me start my presentation. This is my COI disclosure. So the title I was given was Acute Heart Failure, What is New? And I would say nothing new, and even more question emerged. And I'm gonna spend the next, probably 40 minutes, 50 minutes to explain why I think so. Okay, so this is acute heart failure now. Like probably you guys also see such not that X-ray for a patient was coming with dyspnea in the emergency department, and then what the prognosis have been changed, how the prognosis have been changed. That's like you can see it in the left right panel. It's showing the 30 days, 1 year all-cause death and readmission rate changes, temporal changes in the all-cause death and the readmission rate of the acute heart failure. As you can see, like we see slightly decreasing mortality, but it's not super, sort of astonishing. It's very little decrease. And also some data show that it might be we might be seeing a little bit increasing readmission rate. So what we are seeing, I mean, this data show this that we are not doing good enough. And also whenever we see the patient with acute heart failure coming to the emergency department with the dyspnea, for example, so what we need to focus on is to how we can decongest the patient with acute heart failure. It's like they're coming with the severe symptom. So what we want my patient to do, I mean, the C is the in decreasing the symptoms like dyspnea. So anyway, of course we need to think of what kind of drugs we need to use for the patient without acute heart failure coming to the emergency department. Still, like first thing we really need to focus on is to get how we can decongest the patient successfully. So although there should be many ideas regarding what is optimal decongestion, I would like to apply PDCS cycle, the plan, do, check, act cycle to the decongest therapy. As you know, so PDCS cycle is a four-step model for carrying out changes. Just as the circle has no end, the PDCS cycle should be repeated again and again for continuous improvement. So what the plan for the decongestant therapy for a patient with acute heart failure? Probably it's in terms of the management of acute heart patient, plan means plan your treatment, and first thing we need to do for that is to evaluate whether the patient is with congestion or not. Of course, we always do this by physical exam. For example, it is not so much likely to see many patients without clinical signs of congestions. This is a registry of hospital patient with heart failure in Europe. And as you can see, only very limited percentage of patient with acute heart failure are without coming with to the need is hospitalization without the symptom relates to congestion. And you can see that this is purple, the percentage of patients represented by purple, and the green are showing how or what proportion of patients coming without any congestive symptom, but you can see the very little. And then also in a study combining three prospective multi-center registry done in Japan, around 70% of the patient needed hospitalization due to heart failure were treated with intravenous diuretics in acute phase. So because it's like because diuretics is the drug that has only one reason for use, get the pee out and decongest the patient, and this results to this at least like many patients need diuretics, which means that many patients are coming with the congestion as a patient with acute heart failure. So it's like it's oh sorry, I think something going wrong. Wait. Uh,
It's like something about the
yeah, it's like I'm drawing something, but I didn't. And
if
wait.
you want, doctor, stop sharing your screen,
Yeah, I
okay,
once I can share, stop
and
sharing.
share it again. Okay.
Okay, wait. And I'm going to share my screen once again. Can you
Yeah,
see that?
it's very perfect.
And I shouldn't click anything properly. Okay, then when were we? Okay, then so next I think due stands for due. And in the process of the congestions, I think due means the giving intravenous diuretics to the patient if you consider the patient has clinical signs of congestion. Important point is that although there is no randomized clinical trial that show the prognostic benefit of our treatment strategy at the acute phase of acute heart failure, it should be promptly done because we have evaluated this hypothesis, the association between time from admission to the intravenous furosemide treatment using the Irregularity Registry, which is the multi-center prospective registry focusing on very acute phase management of Japanese patients with acute heart failure. We sought to evaluate the association between time to first intravenous diuretics. We call it daughter furosemide time, and in-hospital mortality utilizing this registry data. First thing we found is that the median time from emergency department admission to the first intravenous furosemide was 19 minutes in median, which was much longer than we expected because we include all the patients coming to the emergency department with symptom of congestion or the heart failure, but still we just expected. I mean, suppose that we are treating them much earlier than we did actually. And this is a kind of a shocking data we found in this registry. As for its association with in-hospital mortality, meaning the association between the direct furosemide time and the expected in-hospital mortality, we found that there is a significant association between direct furosemide time and in-hospital mortality, which is particularly strong within the first 100 minutes of admission. this study results should be interpreted as with the caution because this is just a observational study. It's not the randomized clinical study that to test the hypothesis that the early treatment can reduce the in-hospital mortality. But probably you can agree with the opinion that there is no reason to delay decongestant therapy as long as the patient has clinical sign or symptom which leads to the congestion. So I think the first or maybe diuretics, loop diuretics associated with lower in-hospital mortality. So next thing we need to do is check. Because of course you all of us know that diuretics work in the different diuretics work at the different part of the renal function. But some patient, especially patient with acute heart failure and or chronic kidney disease, may not respond as well as we expect, even if we give the intravenous loop diuretics to such patient compared to healthy person. You can see in this figure that's x-axis is representing the loop diuretic plasma concentrations. You can see that equal to as the how much your diuretics you're going to give to your patients, and the y-axis it's in the sodium excretion, and also it can be equal to the urine output, I mean response to the diuretics. So in the right line, so this line is representing the association between the how much loop diuretics you're going to give to the patient and the how much the patient is going to pee out. But you can see that this is like a similar card. Like if you give some amount of the diuretics, the patient start peeing suddenly, and it's the response is those the quite those responding. However, the pay for the patient when they come to the patient with acute heart failure or chronic kidney disease, this response curve go down, which means that even if you give it some amount of the diuretics, the patient will not respond well to the certain amount of the diuretics compared to the healthy person, and also to the right, which means that you need to give more diuretics to get a certain amount of urine output compared to the healthy person. So I think this is what we call the diuretic resistance or the poor diuretic response. Probably if you have experience of treating a patient with acute heart failure with the diuretics, you can see definitely you can see there's some great variation or disparities in how much the patients pee out to when they were given certain amount of the diuretics. They never respond exactly as the same as the everyone. So I think this is what we call the diuretic response. So even though everyone knows, all of the cardiologists treating the patient with acute heart failure know about this, there is a disparity in diuretic response. Actually, some physical mechanism behind this, the diuretic response disparity, this diuretic response has not been well evaluated and also not well understood. Of course, we know that the patients with the renal dysfunctions, low albumin level or the serum albumin level, and also the low cardiac output, the low blood pressure, are not responding well to the diuretics, but actually it doesn't, so explain everything about regarding why the patients respond very differently to the certain amount of diuretics which was given to the patient. However, one thing we are pretty sure is that this diuretic response is strongly associated with prognosis. So this is a first paper coming out from colleagues and the Dutch colleagues, the Groningen group, the published in European Heart Journal, 2014, and they clearly showed us if the patient respond well to the certain amount of diuretics, the prognosis is good. But if the patient doesn't respond well, so the patient prognosis is quite bad, poor prognosis. So this station seems to be almost linear. So the more the patient responds to the diuretics, the more likely the patient is going to have a better prognosis compared to those who are not responding well. We also check this the phenomenon using our registry data, and it's like we evaluate the 1,500 patient with acute heart failure from Reality HF registry cohort, and then we found that even if you check the urine diuretic response, which we calculate diuretic response in this evaluation by how much urine output within 6 hours achieved by the 40 milligram the proximal equivalent dose of the therapeutics, but still, if our data is showing that the 6 hours will be enough to see who are responding well to the diuretics and who are not responding well to the diuretics, because when we divide all the patients into the three groups according to total of the diuretic response, the T1 total one, which means that this is a group which respond the least to the 40 milligram furosemide. The 60-day mortality is quite high, like 11.8%. When it comes to the patient who responded the best to the certain amount of therapeutics, it's only the one third, only the 3.6% mortality within 60 days. So there is a strong association between the diuretic response measure within only 6 hours after you give the patient after you give the diuretics to your patient. So this is why you need to check whether your patient is responding well to the diuretics you give to the patients, because they are not responding equally. So there is great disparity, and you can understand that your patient's diuretic response only after you give the patient if only after you give your patient the intravenous diuretics. And also the nodal analysis we did for this paper, so we found a very interesting result. And this is a result of the match variable linear regression analysis to see what kind of the baseline data are associated with the diuretic response achieved within 6 hours. And these 7 factors or factors are strongly, these 7 factors are independently associated with the diuretic response within 6 hours. And then you can see that the creatinine is associated diuretic response in the negative manner, which means that the high creatinine is associated to poor diuretic response, which is very reasonable. And at the older age and the patient who are already on diuretics at baseline, and the high white blood cell count and high potassium are associated with poor diuretic response. However, like also the low albumin and high BNP, which are almost completely understandable to me, at least. But anyways, even if you can't take into account all of these 7 factors, you can estimate that only 14% of the diuretic response. So of course we know that all the patients are not responding well, and also patients with the low albumin level are not responding well. But still, these are only the small part of the factor explaining the diuretic response in patients with acute heart failure, which means that we actually don't know almost nothing about how this diuretic response has been determined from patient to patient. So that's why you really need to check the diuretic response for every patient you treat. And next things, it has the, it's a act, which what it acts. So, you know, so probably we don't know, as I told you, like, we don't know, we don't have much trouble in patients who respond well to the intravenous diuretics. But the thing is, what to do for those who do not respond well, or the who do not respond as we expected, as much as we expected. So take a look at the guidelines. The proposed guideline proposed that if the patient's blood urine sodium is below 50, from 50 to 70 mg per liter, and or urine output is less than 100 milliliter per hour, the intravenous therapeutics should be doubled. You mean the dose of the intravenous therapeutics should be doubled. The algorithms emphasize the reassessment every 6 hours with dose adjustment until the maximum intravenous group diuretics is reached, which was proposed as the 400 to 600 milligram. But I think it's too high. I mean, super high. I'm not sure if you guys are doing this as well. At least we are not doing so. So, and if it doesn't work, we need to start thinking of combination therapy, which I will come back to later. Come back to it later. And but in at least this is a the statement published in the European Journal of Heart Failure in 19. The guidelines. This guideline said like a first line is thiazide, and the second line acetazolamide or amiloid, even though it was this paper has been published before the trial. And the SGLT2 inhibitor was described as the less recommended therapy compared to other the combination therapy using the acetazolamide or the thiazide. So again, well, again, this is the fundamental concept of decongestive therapy, which I believe that evaluate congestion. If the patient is congested, give them intravenous the diuretics as soon as possible. I think at least no reason to wait or relax and check if the patient responds properly to the diuretics given, and he or she doesn't respond well or respond as much as you expected. So you need to take an action, because if you don't, the patient is likely to have the poor prognosis according to some data published already. Okay, then. So now we according to several studies published in the recent decade or a decade or something, that then are we really doing the process better than before? I think probably not really. This figure showed the distribution of the changes in patient body weight from admission to discharge, comparing the data from the trade aid registry, which was done from the year 2015 to 2012, 22, with the Adhere registry, which is a much older one. So like the Adhere registry was done from the 2001 to 2004, I think. So it's been that's so looking at the chart, we can see the majority of patients experience the weight change in the range of the -5 to the +5 pound, with around the 28 from the trade age group and the 33% from the Adhere group registry data showing minimal changes. And more importantly, around 20% of the patients were discharged. 20% of the patients discharged with increased body weight from the admission to discharge. I mean, and this distribution highlights that despite advancements, the overall approach to decongestant treatment has been largely unchanged over the years and not good enough So our strategies need to improve, especially for patients who do not experience a significant weight loss during hospitalization. So let me get back to the guidelines. The data I've just showed you clearly suggest that what we need to improve event treatment for those who are not responding well to the intravenous diuretics given as an initial therapy. In other words, patient with poor diuretic response. The two strategy guideline proposed are once again, so urinary sodium concentration guided therapy, in which I explained you before, and a diuretics combination therapy. So these are the two strategies we can take to enhance the better decongestion. So okay, what the data there? What kind of data we have for these two strategies? So let's take a first look at the data of the safety and effectiveness of urinary sodium guided therapy. This is an ENACT HF, which was designed as a two-phase sequential study to test the efficacy of the protocolized decongest strategy guided by urinary sodium concentration you got after you give the patients the intravenous furosemide. 401 patients were included, and the study result demonstrated this strategy was safe because you can see that there is no difference in the safety endpoints between groups. And so and I'll say the word and also the urinary sodium concentration guided therapy was associated with more natriuresis units until 2 days and the shorter length of hospital stay. It's a significant, there is a significant difference between groups. However, this strategy did not result in more weight loss and the better the decongestion measured by congestion score and lower mortality. There is no significant difference in low mortality between groups. And the push edge, which is the design and executed by my Dutch colleagues, Kevin Daman and Yojin Termatan, was a single center open label randomized clinical trial testing the safety and efficacy of the urine sodium concentration guided decongestion therapy. And they randomized more 310 patients into two groups, which one is allocated to the interventional therapy, which means that they are treated with urinary sodium concentration guided decongestion strategy. Another one is just conventional therapy group, and they showed us the result they showed is very similar to ENACT HF, the result of ENACT HF, which means that's a protocol decongestive therapy guided by urinary sodium concentration achieved after intravenous loop diuretics was safe. You can see there is no safety difference in safety out endpoints between groups, and effective in achieving more 24-hour natriuresis and urine 24-hour urine output, but it did not lead to a better 180-day all-cause death or heart failure hospitalizations. So, it's like into these two, I believe that these two studies have demonstrated exactly the same thing during the decongestion therapy or strategy using the, urinary sodium concentration guided by urinary sodium concentrations is safe and effective in achieving more natriuresis, but it did not it did not change the patient prognosis. So let's focus on the approach, the combination diuretic therapy. The combination diuretic therapy strategy has been around for a long time, but very few changes have been observed in real world practice. This, however, this figure are showing the what percent of the patients with acute heart failure have been treated with this the additional. It's not a normal. It's not I won't say it's not normal, but still it's additional therapy for those, especially for those who are not responding well to the regular intravenous loop diuretics. But you can see the belly flat. These lines are very flat. You know. However, I think it's interesting to see that even in this data, thiazide diuretics and this is rated as an adjunctive therapy with thiazide, which are proposed in the guidelines as a first-line combination therapy, having the most commonly used choice over the last 10 years. So this figure overviews which combination therapy target which part of the kidney. So starting with the proximal convoluted tubule, so we feed acetosuramide SGLT2 inhibitor. Acetosuramide inhibit the carbonic anhydrase, leading to reduced bicarbonate and sodium reabsorption. SGLT2 inhibitor, on the other hand, work by inhibiting glucose and sodium reabsorption together, promoting the osmotic diuretics. Moving down to the loop of Henle, we have loop diuretics. Of course, this is probably the the drugs we mostly used for treating acute heart failure and also decongestant patients. And loop diuretics are powerful because they target the site where around 25% of the sodium deabsorption occurs, making them very effective for the volume reduction. And in the early distal convoluted tubule, the thiazide diuretics here it's like that is a thiazide. The diuretics act by blocking the sodium chloride co-transporter, and this inhibition target about 5% of the sodium deabsorption, which is used for harmonizing mild to moderate volume overdose. So the collecting dots finally here in the collecting dots we have mineralocorticoid receptor antagonists and baptans. Baptans specifically inhibit vasopressin 2 receptor, which control water channels, aquaporin 2, in other words, in the collecting duct, allowing for the free water excretion without the significant saline loss. So basically, this drug causes not natriuresis, but aquaresis. So the main concept of the combination therapy is to enhance the sodium excretion by blocking sodium absorption, which is less depending on the loop diuretics, because combination means that you are going to give something else in addition to the loop diuretics. Loop diuretics is the mainstay of the it's like hey, we need to use the loop diuretic anyway. And so if the patient doesn't respond well to the loop diuretics you give, you need to add something. This is a concept, basic concept of the, combinations therapy. So the cyanides, which is all diuretics and some forms, which block sodium reabsorption at early distal convoluted tubule. So is there any data from now on? So I'm going to show you what kind of data we have already for each of the combination therapy, because we need to know that, otherwise we cannot judge which kind of the patient should be treated, which kind of the combination therapy, and then what kind of data we have. And I think probably the Quality trial is the most prominent trial which tested the the clinical impact and safety of the combination therapy. The Quality trial, which is a double-blind randomized clinical trial, included patient with acute heart failure already on the 80 to 240 milligram furosemide or furosemide equivalent dose of diuretics, and its results show that combination therapy with higher thiazide decreased body weight within 72 hours more, but that does not improve the patient's reported dyspneic symptom measured by Likert scale or the visual analog scale. Moreover, you can see that combination therapy was associated with more impairment of the renal function and also severe hypokalemia. So back then, which is probably not approved for heart failure in your country, Colombia, I think, but in Japan it is. Actually, the background is the trabectan is approved for the as a treatment for acute or maybe heart failure, I would say. So this drug, as I explained you before, this drug acts as an antagonist of the vasopressin 2 receptor and subsequently inhibited the absorption of the electrolyte-free water by blocking the expression of the calpain 2 receptor on collecting duct. So it causes aggressive, but not nausea, at least theoretically. So the effectiveness of the safety, of course, of the using terbinafine in patients with acute heart failure was tested in the aquamarine study, which I conducted almost decades ago. And we randomized 220 patients from 19 hospitals in Japan. And all the patients need to have a renal dysfunction, which was defined as estimated GFR from 15 to 60. And we randomized in one-to-one fashion to either the usual care or the using terbinafine 50 milligram once per day for 2 days. And primary outcome was the urine output achieved within the 48 hours after randomization, because we chose this patient population because we already knew that the patient with renal dysfunction is likely to respond to the intravenous furosemide. So this is kind of the high risk population for diuretic resistance or for diuretic response. However, we found that the tolvaptan group showed that 1,500 milliliter more urine output within 48 hours compared to conventional treatment. So also we measured or evaluated the patient's dyspneic symptom using like 7-point Likert scale, and we found that at all time points except for the 6 hours of randomization, the patient allocated to the tolvaptan group showed a more improvement in the dyspneic symptom compared to the conventional therapy group. So I think so at least our data is supporting the using tolvaptan as one of the options which can be applied to the patient less likely to respond to the regular treatment with using the intravenous furosemide or the loop diuretics, I would say. And also a trial which tested the effectiveness of the tolvaptan was the 3T trial. 3T trial was not the trial focusing only on tolvaptan, but it randomized 60 patients with acute heart failure to either combination therapy with metalazone, chlorothiazide, or tolvaptan in double-blind manner. Primary endpoint was changing weight from the baseline to 48 hours, and the results showed that all three combination therapies were effective in terms of the primary endpoint and increase in urine output. But 48-hour spot urine sodium was lower with tolvaptan than with the metalazone and with chlorothiazide. Of course, this is a super understandable considering the mechanism of action of tolvaptan, because as I told you before, that it doesn't cause the natriuresis, but it causes chlorosis. And but as for safety, there is no difference between groups. So acetazolamide is the drug probably the most drawing attention recently as a combination diuretic therapy. It has both intravenous and oral form, but in my country, Japan, it's not approved for heart failure yet. And also we have only the oral form, but we don't have intravenous form. I'm not sure in your country, but which can that's we cannot apply directly the result of the word trial. Of course, all of you guys know that Atwood trial, which was published to 2012-22 in New England Journal of Medicine, and was the first double-blind randomized clinical control trial to test the safety and efficacy of acetazolamide as an adjunctive treatment for acute heart failure. And I believe all of you know that of course it's as effective in using natriuresis compared to placebo, but once again when it comes to the clinical endpoint like heart failure rehospitalization or all-cause mortality, there's no difference between the acetazolamide group and the placebo group. And also, this is not actually the distinct symptom, but that they measure the EQ5D index or EQ5D visual analog scale to compare the effectiveness of these two between the placebo and acetazolamide group, and they found no significant difference in these metrics reflecting the QOL of the patient. So, okay, so lastly, I would like to say something about the CLT2 inhibitor. Of course, the CLT inhibitor is acting on this part. I mean, like acetazolamide, the still because its effect on the patient is acute heart failure has been tested around 4 years before. This study is a very small study, including only around 70 patients with acute heart failure, 79 patients with acute heart failure. And it was done by my friends Kevin Daman in the Netherlands. And then he found that even though they did not find a significant difference in primary endpoint, which combined all of these for a lot of endpoints using Z score, but still at least if you take a look at the urine output or the body weight or cumulative fluid balance, in fact, refrosing given within 24 hours of the admission was associated with the more urine output and the more fluid, negative fluid balance compared to placebo. And of course, this is not the study power to show the difference in prognosis, but you can see that there is a clear signal in terms of the lower worsening heart failure or the death or remission or the heart failure remission compared to placebo. And also, I didn't include in the slide this slide, but the safety endpoint was also tested in this small study, even though it's a small study, but it didn't show any signal regarding the safety concern regarding using the impact reflowing in the very acute phase in patient with acute heart failure. So, and they also showed a very interesting result regarding how SGLT2 cause urine output and in the sub-analysis impact response HF. The impact refracting inhibits the sodium glucose co-transport to in the convoluted tuber, right? So under normal condition, SGLT2 absorb the glucose and the sodium back into the bloodstream. By blocking SGLT2, empagliflozin prevents the glucose from being reabsorbed and leading to its excretion in the urine. This glucose acts as an osmotic agent, drawing the water into the urine, thus increasing the urine volume. So the process known as an osmotic diuresis. This is completely different from the natriuresis. And this this another trial completely show that completely support this idea because this is an impact HF, which is also the very small study which include only 60 patients with acute heart failure, but they include very quick. I mean, within 12 hours of the patient of admission, and they show that impact thresholding once again is associated with more urine output and also the more decrease in T-proBNP. But the interesting finding is they found is that even though the impact reporting was associated more urine output and more negative net fluid output over 5 days, so you can see in this line that there is no significant difference in urinary sodium excretion between the empagliflozin and placebo, which support the finding the impact response group have found in the study I showed you before. And also, once again, impact HF showed that there is no concern or is any signal regarding the concern on the safety of using SGLT2 inhibitor in patients with acute heart failure. So this is the summary slide of the data I showed you in my presentation. Is what I want you to look at is that interestingly, you know, we know that the heart failure or acute heart failure as well is a disease strongly associated with retention of the sodium. And of course, to solve this problem, I mean that to treat the patient with heart failure, it's normal to think that we should the treatment we provide to the patient should at least leads to the sodium excretion, but many intervention which has been clearly shown to cause the more natriuresis has not necessarily associated with better prognosis, even though the number of patients included in the study was not super big. So what does the discordance implies? Should we focus more on other thing or the natriuresis is not a good surrogate for patient to improve the prognosis of the patient with acute heart failure? Actually, we don't know because we don't know, and not all of these kind of therapy reported that what happened to the natriuresis. I mean, what kind of an intervention caused the how much more, how intensified the natriuresis for patient with acute failure. So when it comes to ST2 inhibitors, so there are a lot of studies which have published already, but actually these are the evidence gap regarding within what happened if the patient was treated with acute heart with the CLT inhibitor, sorry, within the very in the few hours after the admission. This is why we now doing the EMPA-HF trial. This is a trial I'm leading in Japan. Now it's in this paper published in European Heart Journal, summarize our study as a patient expected to be in low list of 500, but it's now increased to the 524 patients. And yeah, it's what it's during it's clinicaltrial.gov. So if you are interested, then you can take a look at the studies design and other stuff. But I will show you this shortly. I mean, that's very simply. This is a summary slide of the design of the MPHF that we are going to include the patient with acute heart failure, but not all of acute heart failure, but the patients need to have at least one of these three conditions. One is a patient. First thing is that the patient need to have estimated GFR of the 20 to 59, which means that the patient need to have a renal dysfunction, or the patient have already treated with a furosemide equivalent loop theoretic dose of equal or more than 40 milligram daily before admission, or the patient does not respond well to the first intravenous furosemide within 2 hours in terms of urine output. So these patients, the patient meets this inclusion and also does not meet any exclusion criteria are going to be randomized to either epagliflozin 2 milligram or placebo within 12 hours of presentation to most of the patients to the emergency department. There we adopted the primary hierarchical compass and critical endpoint, which is called usually the win ratio, and combining these four endpoints and combined endpoint. So what we are going to show by showing the result of it by Chef of course, we are going to show of course, in NPI-HF, we are collecting urine sample at the baseline 24, 48 hours after the treatment started. And also we are going to show whether or not the acute phase treatment with a SGLT2 inhibitor is associated with better symptom relief, which are now collecting data are collecting as measuring by measuring the visual analog scale or KCCQ-TSS, and which is the most frequently used metric for measuring the patient's QOL or the dyspneic symptom. And also, of course, we're going to evaluate whether or not putting the patient on the SGLT2 within only 12 hours of the acute heart failure admission is safe or not, collecting the data regarding the adverse event with special interest like diabetes ketoacidosis or renal function and amputation. So let me finish my presentation by saying that diuretics, are still cornerstone of decongestant treatment in patient acute heart failure and also heart failure. The patient with diuretic resistance need to be identified as a high risk by public groups because many studies have clearly shown and consistently show that the patient does not respond well to the diuretics you gave are likely to have a poor prognosis is clear. And the safety of achieving greater natriuresis by intensifying diuretics has been demonstrated in several randomized clinical trials, but its benefit on symptom relief and prognosis, still needs to be evaluated. So I think SGLT2 inhibitor are possibly one of the most promising drug for using combination strategy. Their safety, efficacy, and mechanism of action should be further qualified yet. Thank you very much for your attention.
Thank you very much, Dr. Yuya. The chat is open for questions for everyone. A very interesting trial, the MPI-HF. Doctor, I have one question. We know that plasma concentrations of natriuretic peptides are an important laboratory test because the role of rule out the diagnosis and other stuff. I want to ask you about the other biomarkers that have been proposed in this scenario, like AMRNP, the cancer TGen 125. I even realized that you have doing some studies with roentgenephrine and other biomarkers. What do you think about the other biomarkers that it's proposed in the international um, cardiology scenario?
If I understand your question correctly, I think you want to ask me the question regarding what kind of biomarker can be used to identify those with congestion or not, right?
Yeah.
I think it's a great point. I think, of course, NT-proBNP can be used to identify the patient who are with heart failure, but it's not specifically associated with the congestion symptom or congestion status, right? And also, we have been seeking for a long time to identify the biomarker, which is specifically or only associated with congestion. And in other words, we don't know actually how we can measure correctly how to know how much the patient is congested, to see the changes, how much the congestion have been improved, congested symptom or the congested status have been improved by the therapy we gave to the patient. And I would say I don't know, and also probably no one know. in the world. And but still, there are some promising biomarker. IADM is the biomarker, one of the promising biomarkers, which can be potentially associated with the congestion itself. But as far as I know, so there is no clinical study or randomized clinical study which tested the usefulness of this the biomarker as a congestive as a marker of congestion, which show we should do this or we should do this biomarker to better treat the patients, our patients.
Thanks, Doctor. My last question is, um, I know you are doing the MPI-HF trial, right? To to evaluate the empagliflozin on on early stages of this scenario. Okay, but in your expertise and what is the diuretic protocol in your center to with the use of um, SGLT2 inhibitors and acetazolamide? At what point do you implement those? And um, if you do you introduce them upon admission or only after you consider refractory congestion? Thank you.
No, okay. I think it's a the two drugs you refer to in your question is completely different because one that I said to what first one SGLT2 inhibitor is a drug which is already proposed in the guideline as a class one and evidence level A indication, which means that you need to give the patient you need to give the SGLT2 inhibitor to the patient anyway at any point, because it's a recommendation is regardless of irrespective of the ventricular ejection fraction. You need to give the SGLT2 inhibitor to both HFrEF, moderately reduced, and PEF by guideline indication class one. But acetazolamide is not such drug. Acetazolamide has not been proposed to, it has not been shown to be associated with better prognosis, lower mortality. So it's the drug only for decongestive therapy. So in that sense, I think it's better to put the patient on SGLT2 as much, if you think that the patients can take it. And I think the timing should be as early as possible. And you need to wait. You don't have to wait because you need to put the patient on SGLT2 inhibitor anyway during the index hospitalization, which means that before discharge, which is putting the guideline directed medical therapy putting your patient on guideline directed medicine before discharge is the idea or treatment strategy proposed at a class 2A recommendation in guidelines, European guidelines. So I think first thing you need to think is you need how you can put the patient on the appropriate drugs, which is the drugs which is proposed or recommended by in guidelines. And if it doesn't work much, I think you can go to the acetazolamide or the other, thiazide, whatever, to decongest to decongest your patient better. So these drugs, two drugs, should be used in the completely different purpose.
Thank you, Doctor. We have two questions on chat. The
Mhm.
first one is, what do you think about the use of POCUS, or point of care ultrasonography, to guide diuretic therapy and evaluate like the congestion state of these patients? The second one, what do you think about the guidelines recommendation of use diuretics um, only for symptoms?
I think a first question, I think Plugat is probably I usually do the echocardiography even in the emergency department to see at the how much the heart beating. I mean, sort of is it whether or not the patient has a HFrEF or PEF or what kind of the congestive status the patient have or is on. And but still, once again, I'm sorry, I'm very much depends on the evidence or the clinical scientific data. And as far as I know, so there is no clinical randomized clinical study which show the effectiveness of the using the doing a POCUS in patient acute heart failure to improve their patient prognosis. So I think, of course, it's probably using doing POCUS in the emergency department to the patient for the patient with acute heart failure will give you will give you a very useful and important clinical information regarding your patient. But still, I'm not sure how we can utilize of information to better decongestant therapy according to the scientific data. And the second question, sorry, I think you're mute.
Doctor, is why do you think international guidelines don't recommend the use of diuretic to reduce mortality in AH if they recommend
Mm.
their use only for symptoms?
Yeah, yeah, it's true. I mean, but still, like, when you take a look at the guidelines, you can realize that loop diuretic using a loop diuretics to achieve the better, the optimal volume status is recommended as a class one recommendation. So it's a green. I think, of course, you're right because it's probably no study have shown that using diuretics is can improve the prognosis, but it's ethically in terms of ethics, it's impossible to randomize the patient to the no diuretics group, right? So I think it's a question we cannot evaluate forever in the future, even in the future. So I think, of course, to answer your question, I mean, the question asking me that why the international guideline don't recommend the use of diuretics to reduce mortality in HF, the answer will be there is no, because there is no data, there is no randomized study. But still, we actually don't need such randomized clinical study to show the prognostic, benefit of using diuretics because diuretics is not the, yeah, anyway, for definitely we need to use a diuretics to achieve the optimal the volume status in patients with acute heart failure. And as I told you in my presentation, this is the first thing we need to focus on whenever you see the patient with acute heart failure in the emergency department when the patient has decongested symptom. Sorry, it's a congested symptom. Yeah.
Thank you, Doctor. I don't see any more questions on chat. Ladies and gentlemen, as we conclude this excellent session, I want to extend our deepest gratitude to Dr. Yuya for sharing his profound knowledge on this subject. On behalf of the cardiology program at the University of Antioquia, thank you once again for your time and dedication, Dr. Yuya.
Hey,
Wishing you all the best in your future. Um, Goodbye, and stay well.
thank you very much. I see you guys. Bye.